Greetings and thank you for joining the Robert Wood Johnson Foundation Systems for Action Research Program and our regular Research in Progress webinar series. Looks like we have a good crowd with us logged in on the online visual portion of today's webinar series, and we certainly invite you to join in, to link in on that portion so you can follow along with the slides today. And if you're not by a computer and are joining us by phone only, we're glad to have you as well. Again, thanks for joining us today. My name is Glen Mays. I'm the, for those of you who may be new to our program, I'm the director of the Foundation Systems for Action National Coordinating Center, and I'm very happy to be here with you all this afternoon. This Research in Progress webinar series is something that we do regularly, a couple times each month. It's an opportunity for researchers who are involved in the Systems for Action program to share preliminary findings, early work that's in development, research that's in development or underway related to the Systems for Action research agenda. And for those of you, again, who may be newer to the program, this is a relatively new program created by the Foundation about a year ago now, designed to build evidence around how to achieve the Foundation's action framework of building a culture of health. And in particular, the Systems for Action research program studies ways of better aligning the delivery and financing systems that support health and well-being across the country, and in particular how we can better align public health, medical care, and the broader constellation of social services in ways that can improve health and well-being and also address health inequities. For those of you who have tuned in earlier editions of our webinar series, you've heard some great work already presented this summer and on fall on some of our collaborating researchers who are implementing studies that have been the first generation of studies that have been funded under the Systems for Action research program. And today you're going to hear from some of the work that's underway, some of our intramural research that's in progress and underway through the National Coordinating Center that's based here at University of Kentucky. And you're actually going to hear from me today, so it's only fair, as we've had colleagues presenting over the past few months, that I'm going to step in and share with you some research that we're leading that we have underway as part of this program. So we're pleased to do that. So again, I am your presenter for today. And I'll be talking about some work that we have underway looking at income and health inequalities and how they're related to population health delivery systems. As I mentioned, this is work that that is very much in progress. So I'll be sharing with you some very fresh preliminary work that we're doing in this area, and we are eager to get your feedback and ideas and thoughts about how to take this forward. Our commentator for today's webinar is also a colleague, a great colleague with me here at the University of Kentucky, Jim Ziliak. Jim is a colleague over in the Department of Economics here at UK, and professor there in economics, and also Jim directs the Center for Poverty Research here at the University of Kentucky, and has been one of our original collaborators in the Systems for Action research program with the Robert Wood Johnson Foundation. So I'll spend a little bit of time stepping you through some of the work that we now have underway in this area, and then we'll turn it over to Jim to hear some of his thoughts about what we have underway and perhaps ways of expanding it and improving it over time. I'll make sure that we preserve time also to hear from you all who are with us online from wherever you might be today, to hear your comments and thoughts and questions before we wrap up today's hour. In terms of the process for submitting your comments and questions, we encourage you to use the chat function, which is on the again, the web-based portion of today's webinar. You should see a chat box on the lower left-hand side of your screen. You can type your comments or questions in there. And when we get to the Q&A portion of today's webinar, I will make sure that we get to those comments. So, but I definitely encourage you to use that chat box as we move along today's session. So without any further ado, again, I'm your presenter for today. I'm a professor here at the University of Kentucky in the College of Public Health. I'm again, I function as the director of the Systems for Action Research Program, and I also lead one of our research centers here at UK focused on public health systems and service delivery. And I'm personally based in the Department of Health Management and Policy here at the University of Kentucky. So I'll be sharing with you again some work that we have underway looking specifically at income related inequalities in health and what we're beginning to uncover about their relationship to the delivery systems for supporting population health activities around the U.S. And so let me spend just a few minutes kind of motivating today's talk. Obviously, there's growing attention being paid to the issue of strategies for improving population health in the U.S. And we know that the U.S. spends far and away more than any other country on the planet spends more on health and health care. But when we look at the amount of health that's produced in the U.S., we're now in the bottom third of high-income countries when it comes to measures of life expectancy, measures of preventable mortality, and many other measures of health at the population level. So this is obviously an ongoing area of issue of concern for the U.S. is how we can realize more health impact from the resources that we expend in our health and healthcare systems. And we're also learning about more and more about the fact that we're losing ground in population health related to, relevant to again many other countries around the world. Other high-income countries are making larger and faster gains in population health, faster gains in life expectancy than we are in the U.S. So we are falling further behind many other countries. Our rate of improvement in life expectancy and other measures of population health has appeared to slow down a bit, particularly during during this since the turn of the 21st century, over the last 15, 16 years. As this slide shows, work by Case and Gatton that has gotten a lot of attention on this issue over the last year or so. There are actually, again, population segments in the U.S. that are now experiencing increasing mortality rates. In particular, the cohort that Case and Gatton's work has pointed to is a cohort of white Americans at midlife, particularly males at midlife. Again, yet another signal that we need to find ways of making greater improvements in terms of population level improvements in health status. In another recent study that has kind of called attention to these issues is work that Raj Chetty and colleagues published earlier this year in JAMA, giving us a very granular picture of income-related disparities in population health by putting together some very interesting data, again granular data by linking tax records to mortality data across the U.S. We're able to see measures of how life expectancy varies across the income spectrum. And one of the interesting findings from this work published earlier this year is the fact that that income gradient in life expectancy varies pretty widely across communities. Again, particularly at the lower income side of the distribution, as this slide shows you. Just 4 metropolitan areas that have vastly different levels of life expectancy for the bottom the bottom percentiles of the income distribution, but virtually very little variation at the higher income portion of this distribution. So suggesting again that where you live really matters for your health outcomes, particularly for those at the lower end of the income spectrum, and raising lots of questions about again what factors may give rise to these patterns. Chetty's work showed that geographic variation that we see in life expectancy for individuals in the lowest income part of the distribution were not significantly correlated with measures of access to care or measures of health insurance coverage. Again, suggesting that again the drivers of this pattern may not be related to, directly to simply just access to medical care, but other factors may be at play. And so obviously that's motivated us to wonder and begin to examine how elements of the public health system and elements of the larger constellation of organizations that support population health activities, whether those strategies may be related to the patterns that we see in terms of income-related disparities in population health. Again, we're at a time now in the policy sphere where there's lots of conversations happening about how we can improve health on a population-wide basis and how we can better support population health improvement strategies. This work summarizes, again, some of the approaches that are being used to define what we mean when we talk about population health improvement. And generally, we're talking about ways of improving health status on a large scale, on a neighborhood or city or county or regional level. And to do that, these improvement strategies need to be able to target fundamental and probably multiple determinants of health. Again, not just limited to looking at issues around access to medical care, but looking at larger health and social and economic determinants of health. And again, to do that, it's likely that these types of large-scale population health improvement strategies are going to have to involve coordination in mobilizing actions of multiple stakeholders, probably in government and the private sector, how we get multiple stakeholders involved in supporting large-scale population health improvement activities. So these are some of the issues that, again, we're beginning to think about and look at approaches for studying as we think about population health. We also know from work in health and work in related spheres that there are lots of barriers that need to be overcome if we're going to succeed in mobilizing collective actions, multi-sector collective actions that target population-level health issues. In this slide, I just remind us of the great work that Eleanor Ostrom did over her career studying collective action problems in health, in social areas, and in environmental policy areas. And we know there's lots of reasons why organizations, both government and private, fail to work successfully together in mobilizing collective actions on large-scale problems. Incentives that are not well aligned, costs that are not well distributed or evenly or equitably distributed across actors, time lags between when you have to implement something and when you can expect to see improvements or returns from those activities, a lot of uncertainty about exactly what strategies are going to work, information problems, and insufficient institutions for supporting the coordination functions that need to happen. So these are kind of well-documented problems with collective action that certainly are present when we think about strategies for large-scale population health improvement. There are also things that we know are likely to be helpful in supporting collective actions around population health improvement, and a body of literature and a body of research that points to strategies that are potentially helpful in supporting collective actions in health. And the slide I'm showing you here is actually from some work from the National Academy of Sciences, a consensus report published a few years ago on strategies for improving the public health system. And actually, these are strategies that are now being called foundational capabilities for population health that have really been around for a number of years now in terms of being documented in the research literature, as well as documented in a number of Institute of Medicine reports going back even as far back as the original 1988 report, IOM report on the public health system, and basically points to the kind of strategies you see here, needing strategies in place for engaging stakeholders in population health activities, strategies that can be used to assess health needs and health risks within populations, strategies for prioritizing those health risks and needs, and then identifying evidence-based actions that can address them, ways of coordinating planning and policy development activities across organizations and sectors, strategies for mobilizing multi-sector implementation of health services and health policies, and then finally having strategies in place to monitor and evaluate the results of collective actions in population health and feed that information back to stakeholders who are involved in the process. These are again activities that have been studied for a number of years now, and that certainly show promise as being, again, mechanisms that can facilitate the kind of cooperative behaviors and activities that can support population health improvement. These are also activities that are reflected in the Robert Wood Johnson Foundation's Culture of Health Action Framework, which motivates a lot of the work that we're now doing in the Systems for Action research program. So definitely very, very consistent with the Foundation's larger strategy for building a culture of health. So those are kind of reasons why we're interested in studying this connection between population health activities and the income-related health disparities that we're learning more and more about through research on this area. And the research in progress now that I'm going to share with you is designed to tackle a couple of related questions. First of all, we want to take a look at what we know about the delivery systems that support those foundational population health activities that I just mentioned, that have been widely recommended by IOM and other bodies for multiple decades now. The community engagement, health assessment activities, planning, policy development, and evaluation and feedback work. How strong are the delivery systems that support those kind of collaborative population health activities? And what do we know about how those delivery systems for population health activities, how they vary across communities, and how they change over time? Certainly we can think about a number of important developments in recent years that are likely to affect the strength of delivery systems for those population health activities, including the recession and the uneven pace of recovery from that recession, and also where we are now with regard to implementation of relevant components of health reform and the Affordable Care Act. So we're interested in taking a look at the patterns of geographic variation and change in those delivery systems for population health. And then finally, most importantly for today, we're interested in beginning to explore whether there are connections between the delivery systems for those population health activities and the income-related disparities in population health that studies like Chetty's work have pointed out to us over time. Is there a connection between the strength of our population health delivery systems and the patterns that we see with regard to income-related disparities in population health? These are three of the questions that we're beginning to explore with the research in progress I'm sharing with you today. So how are we examining these issues? We're taking advantage of a longitudinal survey that we have been conducting now for for now almost 18 years. That's called the National Longitudinal Survey of Public Health Systems. Some of you who have been fellow travelers with us in the Robert Wood Johnson Foundation's Public Health Services and Systems Research Program are probably familiar with this data source, and others maybe less so. This survey follows a cohort of over 300 communities that are all basically in metropolitan areas. These are all communities that have at least 100,000 residents that we began studying back in 1998 through this survey, and that we've periodically been able to track over time by resurveying these same communities over time. Up through 2014 was our last completed wave of data collection. We're actually in the field now with the 2016 wave, but what I'll be sharing with you today uses data up through 2014. And through this survey, we measure the types of activities that you see here on this slide. We first of all have a series of 20 population health activities that relate back to that conceptual framework, the IOM conceptual framework I summarized just a few minutes ago, measuring the extent to which there are activities in place within the community that are focused on stakeholder engagement, on community health needs assessment, on priority setting and planning around priorities, and on implementation and evaluation activities. So we measure the extent to which those 20 activities are actually implemented in each of these communities, the scope of activity. We also measure the network effects, the range of organizations that are involved in supporting those activities, each of those activities in these communities, both public and private sector. Public health organizations, healthcare organizations like hospitals and physician organizations and health insurers, as well as other organizations working in other sectors. We can also measure kind of the division of effort in terms of which organizations play more central versus peripheral roles in supporting those activities in the communities. And then finally, we have a measure of quality, quote unquote, a measure of perceived effectiveness of each activity. And these surveys are completed by the local public health official in each of these communities, but the official is asked to report on these activities as they exist in the community, regardless of who's involved, of which organization or combination of organizations are involved in supporting these activities. So we again now have data on these activities over a time span that runs from 1998 through 2014. So a 16-year time frame that we can look at geographic variation and longitudinal change in the scope and the network of organizations that are involved in supporting these population health activities. That lets us do interesting kinds of measurement, implement interesting kinds of measurement approaches, including using network analytic methods illustrated in this slide. We can look at which sectors and which types of organizations play more central versus peripheral roles in supporting the range of population health activities that are being measured here. And we can also measure the strength of connections that exist among organizations and sectors as measured by the proportion of activity, the number of activities that are jointly supported by pairs of organizations within each community. The width of the lines that you see here are measures of connectedness and density and strength of connections. So we use these network analytic approaches for measuring the structure and strength of the delivery system that supports population health activities in each of the communities. We also, for this analysis, we make use of a typology we developed now about 6 years ago that allows us to classify communities across the country for this analysis into one of two categories based on how our measurement of the strength of the multi-organizational delivery system that supports population health activities. The first, and this came out of a cluster analysis we conducted and published again about 6 years ago now. These first three clusters that you see here on this slide, on the left-hand slide, are what we call comprehensive population health delivery systems. Because they are all communities that support a large scope of these 20 IOM recommended public health activities, and they do so. They support those activities through dense relationships, dense connections among organizations, multiple organizations that support those activities. So that's the communities that fall into that category of high scope of activity, dense set of multi-organizational relationships that support those activities. Those are the communities that are classified as having comprehensive system capital or being a comprehensive public health delivery system. And you can see other communities fall further to the right on the spectrum and are classified either as conventional or limited delivery systems because they support a narrower scope of activity, and they do so through less dense networks of organizations that support these activities. And again, just to point out, this measure of comprehensive systems is was adopted as one of the Robert Johnson Foundation's national measures of progress toward the Culture of Health Action Framework. And as of 2014, we had about 47% of the U.S. population residing in a community that met that definition of a comprehensive system for population health activities. So we link these data. We have these data now for more than 300 communities over a 16-year time period. We link these data with a number of other data sources that give us information about the health resources available in these communities, that give us information about the demographic and socioeconomic characteristics of these communities, give us information about the characteristics of the governmental public health agency in these communities, as well as information about again, about health resources, hospitals, medical spending in these communities. We've linked these data up with the CDC's compressed mortality file that gives us cause-specific death rates by county. But the most recent and again novel data source that we've linked up to support this particular analysis is data from Roz Chetty's Equality of Opportunity project that I mentioned earlier at the beginning of this talk. That is reflected in the paper from earlier this year, the JAMA paper on income-related inequalities in life expectancy. We use Chetty's local estimates of life expectancy by income quartile, link that up with our data on population health delivery systems to begin to explore relationships between population health activities and income-related disparities in life expectancy. Just a quick note on Chetty's data. His data come from, again, a very novel exercise to get much more granular data on life expectancy by income. He used federal tax records for every filer for every year over the 15-year period, 1999 to 2014, using measures of pre-tax household earnings to document to estimate income for these households across this 15-year period, which closely aligns with our 16-year period for our population health survey data. That data come from a total of 1.4 billion person years of data from the tax records. He then links that up with data from the Social Security Administration on person-level death records for the 6.8 million deaths that occurred over the same 15-year period of time. He uses the mortality data then to estimate period life expectancy, conditional on the income percentile, and estimating life expectancy for persons at age 40 years of age. So looking at life expectancy conditional on survival to 40 years of age, conditional on the income percentile estimated from tax records. He does this at the individual level, but then also uses that to generate area-level estimates of life expectancy by income quartile. And he estimates that both at the county level, and then also estimates that for commuting zones, which are multi-county combinations that basically approximate the metropolitan areas that are also reflected in our population health survey data. So we actually use Chetty's commuting zone level estimates of life expectancy by income quartile in this analysis. So how do we explore the relationship between population health delivery systems and life expectancy by income? We've estimated some preliminary panel regression models to begin to explore this relationship. using a random effect specification to account for the repeated measure nature of our data going from 2008 through 2014. And our data, the clustering of our data, our public health jurisdiction data within states, using random effect specification to account for both of those levels of autocorrelation. We also we're concerned about the potential endogeneity of our measure of population health strength or population health system capital. We know that again, there may be many unmeasured factors that explain why some communities have a stronger population health delivery system than others, and some of those unmeasured factors may also affect these income-related specific mortality, life expectancy measures of interest. So to control for that, the potential unmeasured factors that could confound the relationship between population health and life expectancy, we use a two-stage instrumental variables model to estimate that relationship between population health system and life expectancy. We first model the probability of a community reaching that threshold of being a comprehensive population health delivery system as a function of governing characteristics, agency and community characteristics, and then use the estimates from that first stage probability model to estimate the effect of being a comprehensive population health system on the estimates, the income-specific estimates of life expectancy, while controlling for a host of other factors, public health agency and community and economic factors. And you can see at the bottom of the slide we control for a range of other factors explicitly: population size, density, metropolitan area designation, income, unemployment, poverty rate, racial and age composition, physician and hospital supply, health insurance coverage, as well as state and year fixed effects in this analysis. And again, we're using the IV estimation to try to control for any unmeasured factors that jointly affect the population health delivery system and the life expectancy. I know I need to speed up a little bit here. This slide is kind of the eye chart here. It's really more for you who may have an interest in looking at some of the details offline. This slide shows you the 20 specific measures of population health activities that are captured in our survey data, and looks at the beginning and ending period kind of prevalence, the availability of these 20 activities, and the degree of change that we see in aggregate over this the 16-year period of time. And overall, for the average U.S. community, we're seeing improvements in increases in the availability of these 20 activities, but the extent to which they increase varies pretty widely across activities. We do see some activities that have declined in their implementation over time. In particular, service number 16, which is the function of linking people to needed health and social services. We've seen a pretty significant decline over time in communities reporting the ability to having a robust capacity for that linkage function within communities. We also see some decrements in the ability to monitor, to have monitoring and quality improvement processes in place for implementing health programs and policies at the community level. Overall, the average U.S. community implemented about 2/3 of these 20 population health activities as of the ending time period of our analysis in 2014. We can also look at the range of organizations that contribute to these different population health activities and how that changes over time. This is also an area where we've seen quite a bit of change and also quite a bit of geographic variation in terms of which organizations play roles in supporting these activities. As this slide highlights, we've seen over time, over this full 16-year period, we've seen some reduction in state governmental agency involvement in supporting these activities, and we've seen some notable increases in other organization contributions, particularly contributions from hospitals to these activities. We saw about a 25% increase in hospital contributions to these activities over the 16-year period, about a 23% increase in health insurer contributions to these activities. So again, these are definitely fairly dynamic issues in terms of which organization, what roles are played by different types of organizations and sectors in supporting these activities. Ultimately, these measures get rolled up into our composite measure of which communities are classified as having a comprehensive population health delivery system. And you can see on the top rows of this slide what communities fall into that threshold over time. In 1998, about 24% of the communities met that threshold, and that moves up to about 40% of these communities by 2014. And you can see that was not a smooth linear progression, but there was, particularly during the recession years, there was some reduction in these communities meeting this definition of comprehensive population health system capital over time. And obviously we capitalize on that longitudinal variation as well as the geographic variation in this measure to estimate its relationship to health outcomes and life expectancy. This next slide I'm showing you, again, preliminary estimates. These are definitely very preliminary estimates at this stage and very much work still in their progress. These are estimates from our first stage model of estimating the predictors, the factors that are associated with a community moving to comprehensive population health system capital over this 16-year period. And I've just pulled out some of the significant variables from this first stage model. Not surprisingly, larger populations, more likely to move to comprehensive system capital, and communities that are growing in their population size. Again, a 10,000 person increase in the community is associated with about a 3.3 percentage point increase in the likelihood or probability of meeting that threshold of being a comprehensive population health delivery system. Poverty kind of moves in the opposite direction. As poverty increases, communities are less likely to move into that threshold of being a comprehensive public health system. The last four variables you see here on this slide are the variables that we actually use as instrumental variables for this analysis. These are variables that that mostly reflect governance and decision-making structures that are in place or not in place at the community level that we hypothesize to be associated with the likelihood of moving to comprehensive population health systems. So these are variables that are associated with the strength of the delivery system for population health, but that we thought would likely would not have a direct effect on our measures of health outcomes and life expectancy in this analysis. And these are variables that we've used similarly as instruments for similar studies looking at the health effects that are attributable to population health and public health interventions. The measure you see there of whether or not a local board of health exists that has policy-making authority at the local level, that being strongly and significantly predictive of a community that will move to a comprehensive population health delivery system. Conversely, communities that are served by a local public health agency that operates as a centralized unit of the state health agency, significantly less likely to move to comprehensive system status. And similarly, communities where the public health agency has local control of the health budget, and communities where the local government has the authority to implement a dedicated health tax or health fee that can has the authority to raise funds locally for health-related activities. Those are all authorities that are, again, significantly and positively associated with the likelihood of moving to a comprehensive population health system structure over time. This next slide then shows you the results, again, preliminary results from our second stage of this estimation strategy, where we're looking now at the effect of achieving comprehensive population health system capital on income-specific measures, estimates of life expectancy using the Chetty data. The first set of rows here that I'm showing you are results from our single equation. These are single equation fixed effects estimates where we're not using the instrumental variables technique to try to adjust for any of the unmeasured confounders that we may not be able to control for directly here. And what you see here are coefficients that are kind of in the hypothesized direction. We see that communities that move to population health, comprehensive system status, we see positive increase in life expectancy for the bottom income quartile. Really no evidence of an increase of life expectancy for the top income quintile. and therefore a reduction in the disparity or difference in life expectancy between the bottom and top income quartile, but none of those results actually achieve statistical significance at conventional thresholds. So they're in the hypothesized direction if we expect comprehensive systems to be beneficial, but not significant. The last three rows on this table show you the results from our two-stage instrumental variables estimation strategy, where we're also able to control for potentially omitted and unmeasured factors that jointly affect population health activities and life expectancy. And there you see the effect sizes are quite a bit larger, and despite the fact that they're estimated less precisely, the standard errors are larger. Here we do see that these effect sizes now kind of reach and exceed conventional thresholds for statistical significance. We see, again, for the bottom income quartile of the distribution, we see that moving to comprehensive population health system status is associated with about a 4-year increase in life expectancy for that bottom income quartile. For the top income quartile, we see basically no effect. And therefore, the net result of that is that, again, moving to population health, the comprehensive population health system status results in a reduction in the disparity in life expectancy between the bottom and top income quartiles, a reduction of about 3 years in life expectancy, which is large and, again, statistically significant. So preliminary work, again, based on, this is just work that we've put together in the last few weeks as we begin to explore these issues. Again, these models also control for a range of other factors that we directly observe and control for in our model, including race, age, unemployment, health insurance coverage, as well as year fixed effects. And so, again, interesting work here. So our preliminary conclusions from this work to date. Again, first of all, just looking at the changes over time in population health delivery systems using our measures, it does look like the country as a whole is making progress. We're seeing more communities move across that threshold of meeting our definition of having a comprehensive, strong delivery system for population health activities, particularly as we get further out from the depths of the economic recession. We're now up to about 40% of U.S. communities reaching that threshold of comprehensive system status. These results, again, very preliminary at this stage, suggest that moving to that comprehensive system status may help to reduce disparities in life expectancy, income-related disparities in life expectancy. This also builds on some work that we have that's now in press that should be out in a couple of weeks, showing that communities that move to this comprehensive population health system capital also see overall larger and faster reductions in overall levels of preventable mortality over the same time period. So the results I just shared with you here very preliminarily suggest that in addition to having an overall mortality effect, the comprehensive delivery systems may in particular help to reduce disparities, income-related disparities in population health. Again, suggesting this may be worth further policy attention in terms of mechanisms for reducing health disparities. As I mentioned, this is very, very preliminary work. We've got a lot more to do in this analytic vein to further explore these kinds of relationships. We are currently testing a variety of alternative specifications for estimating these relationships and testing the robustness of our results to alternative specifications. We haven't yet begun to explore the possibility of lagged effects and begun to try to estimate cumulative effects of population health activities over time, and that's something that is on our short list of work to do as we continue to explore these relationships. And then we're also interested in taking a more finer grain analysis of looking at the trajectories or the different pathways that communities move through over time as they move across the thresholds of meeting our definitions of strong population health delivery systems or comprehensive system capital. So just a few of the directions that we still have ongoing and plan to work in the near future. I'm going to stop there because I want to make sure that we've got time for to hear from my colleague Jim about his thoughts on what we've done so far, and also want to get to some of our questions. So Jim, let me turn it over to you.
Thanks very much, Glenn. That was a great presentation, and thank you for giving me the opportunity to comment on it. So my name is Jim Ziliak. I'm a professor of economics at the University of Kentucky and the director of the Center for Poverty Research. And I am also collaborating with Glenn and his colleagues in the College of Public Health on the Robert Wood Johnson Systems for Action Research. So what I would like to do, because I know our time is limited, is to just comment, make a couple of overarching comments, maybe a couple of suggestions about pathways going forward. First of all, I really enjoy this paper, and it's building on a series of projects that Glen's been working on with different co-authors over the last several years, using this incredibly rich data set on public health service systems. And what's also particularly nice about this work is it's an attempt to go a step further beyond the kind of the widely cited work by Chetty and co-authors in JAMA this year that looked at associations between these community-level life expectancy and other potential factors. And so Glen is pushing it beyond, I think, kind of the simple association and trying to make a step forward towards a little bit more of a causal analysis between public health systems and public health outcomes. So for example, Chetty et al. Found that health behaviors at the local community level, one of the strongest correlates with life expectancy. So life expectancy fell as kind of negative health behaviors increased. And so what Glen's research is suggesting is that as communities come together to confront these public health issues, that the more comprehensive type of system that they have to address these community health needs, that they're more likely to realize substantive gains, and that these gains are going to be biggest for those individuals with the most to gain, i.e. those who have low incomes and low life expectancy. So I think that this is a really nice move forward in the literature from Chetty and others prior to Chetty. So I'm to applaud Glen and his co-authors on this line of work. There's a couple of things that I think some of it flows out of the Chetty, and I think it flows forward into this line of work, and that is, there's a couple of things. I'm a labor economist by training, and so there are two things that kind of stick out in looking at some of this work, and that's the nature of work differs dramatically across these communities, and so while we see the income life expectancy gradient is much steeper in, say, Detroit, Michigan compared to San Francisco, and I think some of that is that the nature of work in the Detroit metro area is different than the nature of work in the San Francisco metro area. So, for example, the risk of on-the-job injury or fatality is much greater in kind of heavy manufacturing-intensive communities than it is more in the service-oriented communities. And so, the type of work, so the industry and occupation concentration in a community, I think would help us go a little bit further to understand kind of the role of income in determining life expectancy differences. And again, with my labor economist hat on, the other thing that really is striking is the potential role for human capital. Chetty et al. Showed a much stronger association with gains in life expectancy in communities with a higher share of college-educated. And I think probably what we're seeing with some of Glen's work is that these communities with more comprehensive public health systems are probably those communities that tend to be associated with higher per capita education attainment. Certainly, I would expect them to be strongly correlated. And so, but it begs the question is, what's kind of the independent role of individual human capital, and how can that human capital be leveraged to foster and build up these public health systems? So two areas, I guess, on the labor economist side would be the type of work, so industry and occupation concentration in communities, I think matters quite a bit. And the other is kind of this role of human capital. And I'll give you one example of this. So I've done some work on food insecurity amongst older Americans using both the N. Haynes and the Current Population Survey. And in both surveys, you find that the risk of food insecurity is at least 20% lower, even for those with college education relative to those with high school, even controlling for income differences, race, marital status, and home ownership. And so it does suggest that there's a significant role of education that can be utilized and grappling with some of these issues. And then also, as someone who's done work on Appalachia, one of the obvious strengths of this data system that Glen has assembled with colleagues is kind of that comprehensive and the continuous coverage over almost 20 years now. But there is, one part of the population that was missing, and it's now just being added in the most recent surveys, and that's kind of rural America. And this is where a lot of our kind of acute public health crises are hitting. Some of the Case and Deaton work on rural white Americans with lower education, where we've had these dramatic increases in mortality rates amongst rural America. And so, moving forward, I think we're going to have to attempt to move some of the lens towards some of our rural communities where some of these population health issues are quite acute. And then lastly, again, is borrowing off some of my own work, and that is, the role of the social safety net and how it interacts with the public health system, I don't think is all that well known, and I think it's something that we need to know more about. Many of these low-income Americans who face these chronic health issues are attached to the social safety net much beyond just Medicare or Medicaid, and that would include supplemental nutrition assistance, so the SNAP program. It might be supplemental security income. It might be disability income. It could be the WIC program. And so how our broader social safety net systems interact with the health system, I don't think is all that well known, and has not been aggressively utilized, I don't think, in the attempts to improve public health. There are a few, I know, hospitals around the country that are introducing, for example, a 2-item food security questionnaire at entry at emergency rooms to try to provide some additional information on food assistance for low-income individuals who seem to be at risk. And there's been some really interesting work showing the link between the timing of safety net payments and the risk of onset of hypoglycemia and other diabetes-related illnesses. So I do think that there's a lot of scope for research and action on the intersection between the safety net more broadly along with our public health system. And I think I'll stop there and leave it up for questions.
Fantastic. Thank you, Jim. You've given us a great to-do list in terms of where we need to take this work further. And And I appreciate that. I've been taking careful notes, and this is very, very helpful comments and guidance, Jim. So we do have some comments on the chat box, and so let me get to those. We got about 5 minutes to hear from those of you who are with us and submitting questions and comments. We got a couple from my good friend and colleague Randy Boberg at Urban Institute, who notes that, again, often in private markets for health services and products, we often see improvements occur first in the high-end products and the market segments that can access those. And then as products get cheaper and move down market. And so he's wondering whether that dynamic applies in public health or for these population health activities. And similarly, he notes that income and health often correlate with geographic area. So he wonders to what extent are the patterns of geographic variation we see here a function of our historic tradition of relying on local funding and local responsibility for implementing these kinds of public health activities. I would say in the first instance, Randy's comment, I think what we're finding evidence for is kind of exactly the opposite that we're seeing, at least in terms of where we see benefits from public health and population health activities. It seems to have a larger impact, again, as Jim said, on the lower end of the income distribution that are likely to, again, have greater need and also greater opportunity for improvement. So I think that's why we see there seems to be a disparity reducing role of having strong population health systems. On Randy's second point, I think he's definitely right on target here. That's one of the reasons why we see such wide geographic variation in the strength of systems over time, across space and over time. Our primary reliance on local policy and local funding mechanisms for supporting these activities. So that's an excellent insight there, Randy. Let's see, going down a little bit, we also have a question about whether we include a measure of dollars or in-kind level of resources contributed to these activities by the actors noted in the population health system. And the answer there is unfortunately not. We have measures of what activities get implemented and which organizations contribute to them. We don't have a measure of kind of the intensive margin of how much resources or how the intensity of effort around these activities. So we're really studying with these survey data kind of the extensive margin of how much gets done and which organizations contribute to them. So we are missing a bit in terms of the intensive margin, but that's an area of obviously intense interest and looking for future work. Let's see. Moving down our list of comments and questions here. Let's see. Are there others? Yes. So a comment asking, one of the slides seemed to illustrate a decrease in quality-related activities from 98 to 2016 tasks. What does this mean? Is there a possibility that voluntary accreditation of local and state health departments and reporting of community health needs assessment data by hospitals under the IRS requirements, might they be drivers of some of the patterns that we see here? So I think that's a very insightful comment. My hunch is that yes, you're exactly right. Part of what is likely to be driving the uptick in these population health activities over the more recent years of our time span, perhaps are related to the national public health accreditation standards that closely relate to these activities we're measuring, and that also relate to the heightened IRS reporting requirements for not-for-profit tax exempt hospitals to at least engage in the health assessment and community health planning spectrum of activities that we're measuring here. Likely that explains the IRS requirements are explaining the significant uptake in hospital contributions to these activities over our time period. That's my hunch at this stage. We obviously need to take a closer look, and there are some ways of taking a closer look at some of those drivers, external policy-related drivers of change in the strength of population health systems over time. But my guess is the two issues that you've noted are probably at least part of the story of what's driving at least the trends over the last 2 to 4 years. Wonderful questions, and I see that we are now at the top of the hour. So I'll invite you to continue to reach out. This is very much research in progress, as is all of our work under the Foundation Systems for Action research program. Contact us if you have further questions or want to learn more about this or other research studies that are underway through the program. We do have the upcoming webinars you see here. We've got additional webinars coming up on the 9th and 16th and into December. Definitely put those on your calendar. And again, feel free to reach out to us for more information or to connect with other ideas that you have about how to build the delivery and financing systems that can support a culture of health. Thank you so much, everybody, for joining us, and we'll look forward to staying in touch. So long, everybody.